Most of the things that you need, you can find in this statement that we put together last year, published and led by Sean Van Diepen from Alberta in Canada. So, and we, in this statement, even though we don't dictate any type of guidance, or we don't dictate what should be done, at least we've raised some of the issues that can be taken into consideration. So one of the important things we need to understand is that there's a volume outcome relationship in the management of cardiogenic shock. These volume outcome relationships have been studied first in surgical procedures. Now it's being studied with surgeons, we studied with PCI. It's a little bit controversial, especially in a country that does very little with operators that do very little PCI. But you can see here that using more than 106 cases as a reference, the mortality here is 34.4%, and it goes 10% higher to a hospital that treat less than 28 cases per year. So that's an important thing to consider. So why would that be? Because large volume sites are more likely to be academic, located in urban areas, and probably serve as referral hubs. And that's the first thing that I'm trying to hint, is that the spoke and hub model may be a good model to go to develop these teams. Patients at high volume hospitals are more likely to receive evidence-based care, prompt revascularization by high volume operators, and this is what you need. You need expert operators to take care of these very sick patients. High volume hospitals may include multidisciplinary teams who more frequently implement mechanical circulatory support, as the devices that were discussed here by Carl and George, and can care more efficiently for patients with multi-system organ failure. And then high volume hospitals can be hubs that are integrated with EMS and spoke centers with clearly defined protocols for early recognition, management, and transfer that can improve patient outcomes. So the guidelines have not been very helpful, and I'm glad that there are some initiatives by the societies. But what we do know about the management of shock is that it's important to revascularize irrespective of time delays, and that's a class 1B indication based on the shock trial that was done like 15 years ago or more. The use of balloon pump is highlighted in this guideline, but there's not much about alternative devices, or there's not a description of alternative devices for refractory shock. This. And then what to do about these patients? They recommend transfer to a PCI-capable hospital for coronary angiography in patients that develop cardiogenic shock, but they don't go beyond what is PCI-capable. I mean, a small hospital is PCI-capable nowadays. So there's no additional guidance for patients who develop refractory shock after primary PCI and insertion of a support device. So all the development of teams, these are data from the shock trial on transfer. And so a significant proportion of patients were transferred within that trial. And in the IVP arm, 77% were direct admit, 53% were transfer. And in the revascularization arm, 42% were transferred and 58% were direct admit. And those patients that were transferred tended to be a little bit younger, a little bit healthier, but they did well after transfer. So that hub and spoke model can work for the management of shock. We have learned from post-cardiotomy cardiogenic shock with Bridge to Transplant Network that was developed in New York. This was published a few years ago, in where they take patients with LVADs and they send them to more complex programs. I mean, the cases are not that many, but highlights the need of teams that can work on the transfer of these critically ill patients, and how the communications need to be established between the referring center and the referral center. So they developed their own protocols as a bridge to transplant network, and they found that that's associated with improved survival, and they have their own protocols, as you can see there. Then there's another system that was used by the group in Mayo Clinic in Phoenix, in Arizona, where they deploy a team to the spoke hospital, and then they can stabilize the patient, put the patient on mechanical support, either Centromag, Impella, Tandem Heart, Eckman, and then they can transfer to the hub hospital where the patient can receive more care. So this is this is a timeline. So they have a patient with an adverse cardiopulmonary event, then the consultation goes on, then the approval for emergency privileges and insurance is obtained, decision made for the traveling team. The team arrives in the referring hospital, and then they decide what to do, and then the patient is returned to the hub hospital for a recovery versus transplant. Similar thing has been done in Paris with a cardiac rescue program, where they have special mobile units that can deploy a team, insert mechanical circulatory support, and then transfer to a hub hospital. They developed a form just to measure what they do, because this is very important. And in that program, the mortality of patients of more than 62 years was high, 100%. Patients that had to have resuscitation had high mortality, but the other patients, the patients that survived, had a survival of 93.8% at 1 year. So that highlights the importance of those critical early moments and having teams that can care for these patients. So for the scientific statement, we developed this graph that shows that there are many ways to get to the hub cardiogenic shock center, and there are multiple team interactions. See that we're all men in this panel here. So somebody looked at this slide and changed it, and have a female referring in the receiving end of the hub hospital. So anyway, so patients can come from the ambulance, from the field. They can go for the non-shock spoke center, or they can go to a not PCI capable. And there are many ways, but it's important that the shock mobile unit will, and the two teams will establish communication and then decide on what to do with the patient and have expert care. There are also some issues on the training that doctors have in the teams caring for patients. So there's been an appraisal of the need for critical care training for coronary care for the CCU doctors. And this is something that is becoming more important. So it seems that a closed unit staffing model is associated with improved outcomes. The cardiac ICU seems to be best suited to centralize the cardiac care of cardiogenic shock patients, but attending cardiologists and teams may not have the dedicated training to address multi-organ system failure associated with cardiogenic shock. On the other side, the controversy is that MICU may be better suited for management non-cardiac organ failure, but then the MICU trainees are not prepared to manage cardiovascular illnesses and perform common cardiovascular procedures. So there's an emerging evidence that transition from an open, low-intensity care model to a closed unit model with care led by dual-trained cardiologists, intensivists may improve outcomes, and that highlights some aspects of the team. So these are models of staffing for the CICU or ICU according to the hospital. So what we should aim at is to have, if we're going to care for patients with cardiogenic shock, is a high-volume cardiovascular center with around-the-clock house unit coverage by MDs, residents, PAs, nurse practitioners, 1-to-1 nurse-to-patient ratio, mechanical ventilation, invasive cardiac monitoring, transvenous pacing, all sorts of support devices, medical consultants that are available and are on site, and then ancillary personnel, physical therapy, occupational therapy, social work, and then end-of-life decisions are very important, and we need to have a very strong palliative care team. In the end, we have to be careful on how we go about public reporting, because that can deter doctors on how to deal with these patients, and then they may tend to undertreat because nobody wants to be nailed for for having a bad outcome in a patient that was sick in the first place. So one solution has been to take these patients away from public reporting, and I think that the National Cardiogenic Shock Initiative is a wonderful initiative to start protocols around the country and improve training and discuss the care of these patients. So in conclusion, I think that cardiogenic care requires a dedicated teams that can translate the success of Mission Lifeline for STEMI and out-of-hospital cardiac arrest with single activation. There's a volume-outcome relationship, so we should concentrate the care at high-volume centers with trained, proficient staff. CIC models of care are in transition, and the critical care training is needed for cardiovascular specialists. Transfer for cardiogenic shock is possible and associated with good outcomes, and I think new quality initiatives across the country can introduce protocols, collect data, and standardize care. Thank you so much.
Thank you. Are there any questions from the audience? Otherwise, I have one. I'm just curious about, in your center, how do you have the structure with the CVICU? Do you have dedicated cardiac intensivists? Do you have dual boarded people? How does your center do this?
So we are a 3-hospital campus. So we have a VA, a university hospital, and a county hospital. The county hospital has a transplant program, and the transplant unit and that special CICU that is mostly surgically led with anesthesiologists and intensivists is the way that it goes. We have not transitioned yet, and we have not found yet the way to transition to a CICU, a cardiac care unit with dual boarded staff.
This is something we've been spending a lot of time discussing in our practice, and one of the things that's just an operational challenge is there aren't a lot of those people out there.
Correct.
And this is very high acuity care, and so you can't just hire one and expect them to provide 24/7 coverage.
But there's a group. So if you look at that statement, most of the co-authors that are not interventional cardiologists like me, they are dual boarded. And there's a new breed of cardiologists that are getting, and more programs are opening. So I think we're at the beginning of the dual boarded cardiac intensivist. And we're recruiting a new CSU director. And one of the requirements is that this director is dual boarded because of the acuity of the patients.
Great. We have a question in the front here.
The question we have is, in our program, sometimes the patients in the emergency department and the emergency room doctors get the ball rolling, and we get down this path where we kind of are well into treating this patient, going to the cath lab because of our door to balloon time initiative, and in retrospect, you feel like that patient should have never even gone to that because of their frailty index, or, I mean, what sort of things have you done in your program to try to, with education, or try to stop that process from being initiated to begin with? Any advice from that?
Well, we haven't done, so I mean, these are proposed models of care. It doesn't mean that we have them implemented all across the country. I think that different initiatives going on will end up implementing, and I think there's also leading initiatives from professional societies like American Heart Association. I am in charge of the acute care committee, and we're leading towards that. I think the model of care for this patient has to change. Whether or not you take your patient who is very sick to the cath lab, that's a decision that has to be made as a group, and depends on public reporting, depends on your willingness to take these patients, and depends on the resources you have available to take care of these patients. Sometimes you may want to refer these patients and develop a hub and develop relationships with a hub hospital that may take your sick patients. We transfer our sick patients that are in refractory shock across the street from our hospital. We can do up to Impella. We are implementing ECMO now. We have a traveling team that will deploy ECMO in my hospital and then transfer to Jackson, where the surgeons can take over the care and do more advanced and destination therapies or transplant.
Dr. Burke?
Thank you, Burke from Minneapolis Heart. A couple of comments on this. This is obviously our next big issue that we need to tackle, and it's imperative that we have procedures and protocols in place where not just cardiologists, but intensivists and the ED physicians are all involved. We've started a program that we call SWAT, Shock Without Trauma, because so many of a third of shock patients are cardiogenic. So that means 2/3 of the patients don't have anything to do with the kind of things that I can do to make better. But we need to be able to identify those people better in the field so that they can be triaged appropriately. The other thing that I think that we need to do is we need to have a national initiative just exactly along the trauma lines. We need to have shock centers that have exactly level 1, level 2, level 3, exactly what they do for trauma, and have requirements for certain people in the house, certain abilities for different capabilities, and referral centers.
Yeah, and let me add to that. I think that there should be a single activation code when you have a patient with shock, so the whole team that concentrates the volume, the full team that concentrates volume will deploy and take care of that patient.
That's right. Actually, we have, with the Shock Without Trauma protocol, the patient is met by an intensivist and an ED physician in the ED, and the cardiologist is called if they believe that it's a cardiogenic shock type of process, so that the cardiologist can meet the patient in the ED as well.
Yeah,
So in our center, and this is called for action for all of us. First of all, there is a paper by Mauricio about the organization of cardiogenic shock. It's amazing paper, really good. It's a must read for everybody who deals with cardiogenic shock. The other thing, you really have to look at your local resources, and the worst thing you can do is sit on a patient with depressors. If you don't have escalation in your center to ECMO and a VAD, you need to partner with a center that has an ECMO and a VAD. But the more important, most of our patients who transferred to us, they waited 24 hours to 2 days before they transfer. And by that time, the shock is not reversible. They have to move as soon as possible. The longer you wait, this is similar to the golden hour. I don't know if you guys, I used to be an ER doctor and I had ATLS, Advanced Trauma Life Support. There is a concept called the golden hour, meaning if the patient comes with a trauma, the best hour to save him is the first hour. After that, you cannot actually reverse the inflammatory process, the shock, all the other issues that could ensue, and the end organ damage. You have to act really fast. And the worst thing you can do is wait on those patients.